Welcome to this explainer. Today, we're bringing to life an epic battle of fluid dynamics happening right inside the human chest. We're going to take a journey from the microscopic cellular level all the way to real-world clinical treatments, exploring exactly how the body's delicate plumbing system can sometimes go terribly, terribly wrong. Picture this. Imagine the struggle of trying to breathe while a heavy water balloon presses relentlessly against your lungs. Your lungs want to expand. They literally need to expand, but they're physically trapped. This is the harrowing reality of a pleural effusion, a condition where the critical space meant to protect and lubricate your lungs becomes completely overwhelmed by an invading tide of fluid. Here's our clinical roadmap for today. We'll cover the lung's delicate balance, anatomy of a lung flood, the diagnostic detective work, the empyema cascade, and finally, draining the flood. Let's get into it. Section 1. The lung's delicate balance. First things first, a pleural effusion isn't actually a disease itself. It's an abnormal pooling of liquid in the potential space between your lung and the chest wall. Think of this pleural space not as some gaping cavity, but as two sliding panes of glass with just a microscopic layer of fluid between them. But when that fluid builds up, well, that potential space becomes a very real, very dangerous fluid reservoir. In a healthy body, you've got this tiny amount of fluid. We're talking just 0.1 to 0.2 milliliters per kilogram of body weight, acting as an essential lubricant. It's a brilliant coupling system, really. Fluid constantly filters in, and then it's absorbed right back out by the visceral pleura and the lymphatic system. And get this, your lymphatic system is basically a superpowered drainage pump. It's actually capable of absorbing 20 times its normal daily load just to keep your lungs dry and expanding freely. Section 2. Anatomy of a lung flood. So there are two entirely different ways the lungs can flood, transudative and exudative. Imagine a transudative effusion as a passive flood. The lungs barrier is actually completely intact, but intense pressure imbalances in the body's plumbing, like high hydrostatic pressure from congestive heart failure or low oncotic protein pressure from liver cirrhosis, force clear fluid to just passively ooze into the chest. Now contrast that with an exudative effusion. This is a hostile, breached wall. The capillary barrier is literally damaged by cellular carnage and intense inflammation from things like pneumonia or cancer. The walls break down and a thick, protein-rich, debris-filled fluid just floods the space. Section 3. The diagnostic detective work. To stop the flood, doctors have to play detective. For decades, the go-to diagnostic tool has been Light's criteria, which goes all the way back to 1972. It looks at the ratios of protein and LDH between the pleural fluid and the blood. High ratios, it points to an exudate. But there's a pretty massive flaw here. Because it relies on concentration, it actually misidentifies up to 25% of transudates as exudates. This is especially true for heart failure patients who are on diuretic meds that concentrate their bodily fluids. And you know what that means? It can lead to completely unnecessary invasive testing. Enter the new hero biomarker, pleural fluid cholesterol, or PCHOL. Researchers discovered that a cholesterol level in the pleural fluid above 45 milligrams per deciliter acts as a highly accurate, standalone indicator of an exudative effusion. Why? Well, cholesterol is a primary building block of cell membranes, so when you see high pleural cholesterol, you are looking at a direct, visual footprint of heavy cellular turnover, membrane degradation, and fierce inflammatory battles happening right there in the pleural space. And the best part? It bypasses that diuretic flaw entirely. Section 4. The empyema cascade. Now, we get to the empyema cascade, which reveals a pretty terrifying progression. Step 1 is the exudative phase. Fluid leaks into the lung space because of nearby inflammation, like pneumonia. At this point, the fluid is sterile and the pH is normal, sitting above 7.2. But if it goes untreated, we plunge right into step 2, the fibrinopurulent phase. This is where bacteria aggressively invade. Their intense metabolism and the dying white blood cells start producing huge amounts of lactic acid, dropping the fluid's pH below 7.2. The body's coagulation cascade goes completely haywire, throwing these sticky fibrin strands everywhere. Finally, we hit step 3, the organizing phase. Fibroblasts arrive on the scene and literally build a solid fibrous peel around the lung. The lung gets locked in a rigid cage and just cannot expand. Looking at a pediatric case, you can vividly see the disaster we just talked about. Normally, lungs look black on an X-ray because they're full of air. But when a flood happens, you see a dense, opaque white area taking over the chest cavity. And the real giveaway is the meniscus sign, a curved white line climbing up the side of the lateral chest wall. It's absolute proof that free-flowing liquid has completely overtaken the space, squishing the delicate lung tissue inward. Section 5. Draining the flood. So how do doctors restore peace and drain this suffocating flood? Treatment escalates strictly based on the severity of the fluid's pathophysiology. It usually starts with a simple therapeutic thoracentesis, using a needle to aspirate the fluid for immediate relief and lab testing. But if the lab shows that critical drop in pH, below 7.2, we know we're dealing with a hostile, highly acidic environment. That requires leaving a dedicated chest tube, or intercostal drain, in place to continuously empty the infection. For recurrent cases, especially those caused by cancer, doctors might implant a tunneled pleural catheter for home drainage, or even perform tout pleurodesis. That's where they inject medical talcum powder to intentionally scar and fuse the pleural space shut, making absolutely sure fluid can never accumulate there again. Now, to navigate all of this safely, doctors don't just go in blindly anymore. Following the modern diagnostic pathway, using thoracic ultrasound to guide these interventional drainage procedures has become an absolute cornerstone of treatment. Ultrasound lets doctors see exactly where the fluid is loculated or trapped by those sticky fibrin strands we mentioned earlier. It ensures that the needle or chest tube goes exactly where it needs to go without ever puncturing the lung itself. Ultimately, early differentiation between a passive pressure ooze and a hostile inflammatory breach is absolutely critical to restoring the breath of life. When managed correctly with targeted drainage and antibiotics, the outcomes, especially for kids, are overwhelmingly positive. It really leaves us with a profound sense of awe at medical science's ability to conquer the flood within. But it also leaves us with a provocative question to chew on. If the microscopic balance of just a few milliliters of fluid dictates our very ability to breathe, what other delicate balancing acts are happening inside our bodies right now completely unnoticed until the floodgates open? Thanks for joining me for this explainer, and keep questioning the incredible mechanisms that keep you moving every single day.